welcome to the November MAPS Canada Journal Club. We have a super exciting talk today on psychedelics and chronic pain, but before we get started with that, I'd just like to make a quick round of introductions. So if it's your first time here at the MAPS Canada Journal Club, we are a monthly initiative for the academic discussion of psychedelic studies, started by students from University of Toronto, McMaster, Queen's University, and surprisingly, University of California, Berkeley. Now, for our speaker today, we have Dr. Joel Castellanos, who is a board-certified physical medicine and rehabilitation pain medicine physician. Joel serves as a medical director of Inpatient Rehabilitation. Dr. Castellanos' prime focus is improving function using an individualized approach. His expertise with interventional pain techniques allow for an integrative strategy to preserve and restore function. Dr. Castellanos evaluates, diagnoses, and treats all forms of functional disability and pain using a multidisciplinary team-based approach. And so with that, I'd like to turn the tables over to Dr. Castellanos, who will talk more about psychedelics and chronic pain. Thank you so much.
Great, thanks for the introduction. Yeah, my name is Joel Castellanos. I'm from UC San Diego. I'm the assistant medical director and one of the co-founders of the Psychedelic and Health Research Initiative here at UC San Diego. I also did a fellowship in integrative medicine at University of Arizona. Here's a picture of where we do all our psychedelic research at UC San Diego. No, I'm just kidding. This is the main library for the undergrads at UC San Diego. It's actually named after the author of Dr. Seuss, interestingly enough. Here are the key team members of the Psychedelics and Health Research Initiative. We have Mark Geyer, who's been doing psychedelic research, mainly animal studies, since the mid-1970s. He's really been a wealth of information. His understudy is Adam Halberstadt, who is a really big name in psychedelic research. Tim Furnish is the director of Center for Pain Medicine and my clinical mentor. Albert Lin, who is a Nat Geo explorer. He is a UC San Diego professor, and he himself had a traumatic amputation, had really bad phantom limb pain, and through collaboration with Dr. Furnish was able to basically resolve his phantom limb pain through psilocybin and mirrorbox therapy, which is one of the standards of care for patients suffering from phantom limb pain. Fadel Zidan is the director for the Center of Mindfulness and does a lot of really interesting fMRI and functional imaging work. Cassie Veaton is a psychologist and another one of the key players for the psychedelics, the PHRI. Ethan Hurwitz is one of our graduate students who, in his undergrad studies, was part of the Johns Hopkins model of psychedelic research. And then Eric Bire is a director for the Center for Human Imagination at UC San Diego. And I think it's just so cool we even have a Center for Human Imagination. I think it kind of goes to show how open and collaborative the research opportunities are here at UC San Diego. So why psychedelics for pain? When I started in training of chronic pain, everyone talks about, in the chronic pain field, everyone talks about neuromodulation. What that means in the chronic and interventional pain space is the use of electrodes to basically change the use of electrodes and electricity to change the way peripheral and central nerves fire to decrease pain perception. This is a big space. There's a whole conference every year, the North American Neuromodulation Society Conference, where it's really focused on industry like Abbott and Medtronic and their spinal cord stimulator devices. And those things do help a lot of people. There is definitely a utility in them. But it just really boggled my mind that with all of these pain physicians calling themselves neuromodulators, that we were ignoring these substances that profoundly modulate the nervous system in psychedelics. Something, taking a small amount of something can change the way, you know, we interact with our world and change the way we perceive the world. And so that's really what kind of piqued my interest in the potential use of psychedelics for chronic pain. Serendipitously, I had a conversation with that question to Tim Furnish, and he kind of looked at me strangely because he had just worked with Albert Lin on resolving his phantom limb pain through the use of psilocybin coupled with mirror box therapy. And so we had a really robust conversation on that. I kind of made that my whole focus of my research over my fellowship year at UC San Diego in the pain fellowship year, and the rest is kind of history. We collaborated with Adam Halberstadt and Mark Geyer and Fidel Zidan, decided to come up with the Psychedelics Health and Research Initiative. And we collaborated with this position paper on the potential use of psychedelics for chronic pain, and tried to compile as much as we could of the different mechanistic approaches of why this may work. And here we are. We're getting ready. We're currently enrolling our first clinical trial for patients with phantom limb pain using psilocybin. We're doing, and I'll go through that a little bit more in depth later, just the structure of that study. But it's including functional imaging, so I'm really excited about what that's going to show. In preparing the paper, this is a diagram from the paper. We wanted to just look at what evidence was out there already on the use of psychedelics for chronic pain. And so there were a couple studies looking at phantom limb pain. Two phantom limb pain studies from the 60s and 70s, along with the one that Dr. Furnish and Ramachandran published on Albert Lin in 2018. There were several in cluster headaches, but the one that really kind of opened my eyes to the potential efficacy of psychedelics for chronic pain was this study from 1964 by Caston Collins, where it looked at patients who were hospitalized for severe pain. These were patients who had cancer pain, ischemic pain. There were several patients in that study that had, gangrene or, ischemic limbs, as well as neuropathic pain from spinal cord injury. And of these patients who needed to be hospitalized for pain control, they compared LSD to either Demerol or Dilaudid, to really strong opioid medications that are pretty efficacious at treating severe pain acutely. In the first 3 hours, Dilaudid and Demerol outperformed LSD, but after 3 hours, LSD was significantly better than both Demerol and Dilaudid. And after 19 hours, close to 50% of the patients were pain-free. And these were patients who were needed to be hospitalized for severe pain. And so I don't know if there's any practitioners in the audience who treat patients with chronic pain, but if there are, as well as I do, that the tools that we have do help patients, but very rarely do we offer something to a patient where it completely resolves their pain. Most of the pain studies, when there are new modalities and new therapies coming out, the threshold is 30%, 30% improvement. And that is good. So when I see things as a pain physician that completely resolve pain, it opens your eyes, and it made me really motivated to try and push this forward, to try and recreate some of these findings and really answer the question of how strong is the signal between psychedelics and the potential use for chronic pain. Bear with me on this. I'm not great at PowerPoint animation, but I tried my best to demonstrate a very cartoonish version of how we think the mechanism works. Most people in this talk, if you're here, probably know that psychedelics work on the serotonin 2A receptor. Here is our psychedelic smiley face molecule interacting with that receptor. And through that, we know several things happen. First, we know that there's upregulation of genes involved with neuroplasticity, as well as immediate early genes, which are genes that have a big impact in learning. And so we know that we postulate that psychedelics will have a big implication in learning, memory, and neuroplasticity. We know that they inhibit TNF alpha, or tumor necrosis factor alpha, which is an acute phase reactant, something that plays a major role in acute inflammation. And we know that it also activates descending inhibition. So in someone who has a normal, intact nervous system that hasn't had any injury to their nervous system, descending inhibition is activated by several of the serotonin receptors. Interestingly enough, after nerve injury, only activation of the serotonin 2A receptor results in persistent serotonin descending inhibition. So what that tells me is that potentially neuropathic pain, phantom limb pain, other types of pain resulting from nerve injury may be specifically amenable to psychedelic therapy. And then, this is a fairly, well-known image of how psychedelics also kind of help reset neural connections to a more efficient and more healthy default mode network. In patients who have been suffering from chronic pain for years and years and years and years, those kind of, their ability to sense pain and to kind of mold their life around pain and having that pain become part of their identity, I think is another way, besides for the kind of the micro mechanisms, but also like on a broader sense, can allow these patients to kind of reset and kind of view their situation from a different lens. And so, these are all gathered from different papers that we read, and I think it's going to be interesting to see kind of how and it, if there is a signal for psychedelics with chronic with patients with chronic pain, if there is a signal, which of these is the one that is really driving it, and I think that's yet to be determined. And so moving forward, what our approach is by kind of reviewing the mechanistic knowledge. We want to optimize outcomes in psychedelic and chronic pain studies. So, we think that through that preserved descending inhibition through the serotonin 2A receptor, we postulate that nerve injury, specifically peripheral nerve injury, spinal cord injury, maybe post-stroke pain syndromes, may be especially amenable to psychedelic therapy. I think also kind of resetting patients' central neural networks to a more efficient default mode network will help with patients with central sensitization. And then, you know, to be determined on acute inflammatory pain, there is some evidence that actually serotonin 2A receptor antagonists may play a role in improving inflammatory pain as well. So we're kind of starting with patients with central sensitization and neuropathic pain, but you know, we really are motivated to try and see what patient populations this helps the most with, and kind of go from there. In terms of the current state of psychedelic and pain research, I gathered this about a month ago, I think. Here's all of the different clinical trials registered at clinicaltrials.gov. So as you see, I mean, we're doing the phantom limb pain trial here at UC San Diego. University of Alabama Birmingham is doing a psilocybin facilitated treatment for chronic pain. Yale's doing a lot of work on the potential use of psychedelics for different types of headaches. And then I believe University of Michigan is also starting a fibromyalgia study. And I believe there's one up in Northern California somewhere that is also doing either a low back. I think UCSF is doing a low back study, a low back pain study as well. Moving on, I just wanted to touch base on kind of what our study looks like at UC San Diego. So it's a double-blind, placebo-controlled trial, really to evaluate whether psilocybin can relieve or decrease phantom limb pain. To our knowledge, it's the first imaging study and the first longitudinal study of psilocybin for pain. Here's the basic trial design. So we do a baseline fMRI study. Before dosing sessions, we have 2 prep meetings where the patient gets to know the monitors, understands the setting that they're going to be in. We get to know a little bit more about them. Our placebo is niacin. We chose that for a variety of reasons. I think, as most of the people in this you know, meeting can attest, it's really hard to blind patients who are getting psychedelics. I mean, they become unblinded very quickly. But you know, we wanted to do something, so we chose niacin because it does have a little bit of a stimulating effect. Post treatment session, we have a reintegration session, and then 2 weeks later we do another session, followed by fMRI studies at 4 months. So we're going to be able to compare baseline versus post dosing fMRI studies, and you know, I think it'll be interesting to see what that shows. I'm really excited to kind of enroll patients, and enroll more patients and really sort through the data. Here's this is a case series that we just published, I think maybe a month ago, I think it went live, in pain, where we talked with 3 separate patients who had been using psychedelics for their specific type of pain. And it was kind of a diverse patient population. We had one patient with a spinal cord injury, one patient who is suffering from complex regional pain syndrome, and then another patient who just had kind of musculoskeletal arthritic pain, as well as lumbar radicular pain. So, pinched nerves in the low back. And, with varying doses, from, what some may consider a microdose to a larger psychotropic dose, these patients all had, decreases in their pain perception and their pain experience. The patient with the spinal cord injury had increased muscle activation and paralyzed muscles, along with complete resolution of neuropathic pain, as well as improved neurogenic bowel symptoms. Obviously, this is an N of 1, but it kind of reinforces my curiosity in how this could be used in patients who have suffered a spinal cord injury. One of the other things that was interesting in the subject 3 is that she was very passionate about how, yeah, the mushroom chocolate bars really helped, but when she combined the use of the mushroom chocolates with her home exercise and stretching program, she had a much prolonged benefit than just using one or the other. So there may be some amplification effect with things that we know already work. That's what we saw in the case report with Albert Lin as well, where he said, the psilocybin worked, for a certain amount of time for his phantom limb pain. The mirror box therapy alone helped temporarily with his phantom limb pain for a specific set of time. But when he combined them together is when he found the most long-lasting relief. And doing that for just 2 or 3 sessions, he was able to completely resolve his phantom limb pain, which is something in the pain world that you really don't see a lot. So questions that I have, and that I hope we're able to answer through this trial that we're doing, as well as future trials, is, how will different serotonergic psychedelics work with different types of pain? Is it specific to psilocybin? I think that there's a lot of groups that are creating new analogs. And, I think it's going to be interesting to see how that all shakes out. I kind of have answered this question. I think that combined tailored therapy that is individualized is something that's going to help the efficacy with the use of psychedelics for pain, whether that's physical therapy or improving flexibility, or mirror box therapy and motor imagery for things like phantom limb pain and or complex regional pain syndrome. I'm a rehab physician, but I'm housed in the Department of Anesthesia. And so a lot of my colleagues often ask me, like, how important is that altered state of consciousness for pain improvement? Are we able to just put these patients under a general anesthetic and then give them a huge dose of serotonin 2A receptor agonist, and is that going to help? Or is having the patient go through that journey and that process therapeutic in and of itself? I would like to think that therapeutic that journey is important. I think that journey is going to be especially important in patients who kind of have an external locus of control, to help kind of shift them to a more internal locus of control, that they can kind of take charge of their pain from a psychological level. But I think that the reason that I'm most excited about this is because I think it has the potential to work on a lot of different levels, both from like a receptor level, the descending inhibition, to resetting kind of ingrained neuropathic neural networks, to kind of giving that patient a different lens on their own situation. So I think it's going to be a really interesting I said earlier, a very interesting couple of decades to see where this all pans out. And then the last question that I have is, what's the most equitable and efficient delivery method for patients with chronic pain? I think that, you know, ketamine therapy and ketamine clinics is something that is, you know, is not ubiquitous, but it's fairly common in bigger cities. But having someone, you know, be monitored for 6 to 8 hours is something that, you know, is pretty resource intensive. And so I think we have to figure out a way to make sure that the patients who need this can get it, and that we are able to deliver it in a way that is accessible to patients of all socioeconomic statuses. So things that I'm kind of interested in moving forward, we're hoping to submit a paper soon on the potential use of psychedelics for post-concussive symptoms. There's been some anecdotal evidence that has come our way that it's efficacious for tinnitus, which is a common kind of post-concussive symptom. I'm really interested in leveraging the aspects of neuroplasticity in acute injury after a spinal cord injury to see if we can enhance recovery and improve functional outcomes, as well as its effect on neuropathic pain. I want to see how it works for a bunch of different types of pain, whether it's acute inflammatory pain, chronic inflammatory pain, arthritic pain, as well as neuropathic and centralized pain. And then, you know, I think probably our next step, you know, as long as we get funding, we'll probably be looking at complex regional pain syndrome from a pain perspective. And so with that, I'd like to open it up to discussion. I really want to hear people's thoughts, people's ideas, where they think, you know, where they think psychedelics stand in the, you know, the potential use of not only chronic pain or neuropathic pain, but also rehab-related conditions.
All right, thank you so much, Dr. Castellanos. Really great presentation. And if everyone would like to throw in a quick clap, it's down there in the reactions tab. Okay, so I'm going to read off some of the questions that have come in during the talk first. And then if you have any other questions, feel free to just raise your hand, and then I can ask you to unmute and you can ask the questions as well. But for the first question here, Dr. Castellanos, so Burton asks, we know ibogaine is useful for addiction and MDMA is effective for PTSD. Is there any psychedelic in particular more efficacious for treating chronic pain? Has there been any studies comparing psilocybin to LSD to DMT for addressing chronic pain? Thanks.
Not to my knowledge. I see that Court Wing is in the audience. He's a close friend and collaborator of mine who knows this space better than anyone that I've met. But no, to my knowledge, I don't think that we know in particular which, if any, which psychedelic works better for different pain conditions. And that's really why I'm so excited to kind of be at the forefront of answering that question.
Cool, thank you. Next question here is from Kelly, who asks, many people feel that medications are simply a bandage for pain, and they mask the body's ability to detect pain. Unfortunately, most of these treatments are temporary, hence why people must take pain medication multiple times throughout the day. What's the sustainability of these agents, I'm assuming related to psychedelics, and will these be useful in acute pain situations or also useful in chronic pain situations?
I think it's a really good question. Where I see the most potential is, I think as a chronic pain physician, I see patients who have they've done physical therapy 30 times and it hasn't, it's no longer efficacious for them. They have tried epidurals, they've tried all these things, and they've tried medications, and most of them don't want to be on medications. They don't want to take pills every 3 hours into perpetuity. And so I think that if this allows that, if psychedelics potentially have the opportunity to kind of reinvigorate these other modalities to help kind of improve the efficacy of other modalities, I think that's one potential benefit. And then if we can prove that this is something that helps for a prolonged period of time, with single dosages, like let's say it works, it gives patients sustained pain relief for 3 to 6 months with a single high dose, like that is a game changer. That really decreases patients' reliance on those daily medications or monthly procedures or whatever it is.
Cool. And then I'm going to call on Brendan here if you would like to unmute and ask your question.
Thanks. I'm sorry, my camera's broken. This is such an interesting study, but it's incredibly complex, and I wanted to hear what you guys thought about the design and how you intend to mitigate the sort of causality if you see efficacy. I see that you're in San Diego, so obviously, I'm assuming you guys are associated or familiar with the early Ramachandran work.
Oh yeah.
And the means of how that is supposed to work in the brain. And psychedelics also have neurogenic properties. So is it a remapping of that homunculus on the brain that could be responsible? They also have anti-inflammatory properties, but not equally amongst them. So and then there's also the profound psychological relief of that perseveration and hopelessness of chronic pain. So two questions. How did you guys build into your design? I hope you just see efficacy, because then you can just make the proportionate argument, these are way safer than any other drugs. We don't know how they work, but we should just use them. But have you put in your design anything to help you tease those things apart? And have you encountered any resistance from REBs or organizations that's unique or special in any way?
So, I think you bring up a lot of good points. Albert Lin, who's a part of PHRI, wanted to incorporate psilocybin with mirror box therapy together in their first study, and we were like, no, it's there are too many confounding factors there. The goal of this initial study is to reproduce a signal that occurred in the 60s and 70s for phantom limb pain. I think before we start putting the cart before the horse, we want to make sure that this is something that benefits patients at the very basic level. We added the functional imaging to potentially elucidate some of that mechanism, if in fact it does work. But really, it's we want to confirm that the signal exists.
Thanks so much. I think I see these patients all the time at my hospital, and they're an incredibly sympathetic and complex group of people.
Yeah, no, I mean, I think, I mean, to your point, I think that, when you see these patients and you see real, we talk about pain a lot, but we don't really like touch on suffering. And these patients are suffering, they, the way they describe this phantom limb pain is like a constant burning, like their leg is constantly on fire, that their leg is constantly being crushed, that there's 1,000 needles in their leg all the time. And we have some things that can help, but for a lot of patients that help is incomplete. And so we need something. I'm really hopeful that this is something that can give profound relief for patients. And then I think you also asked about kind of regulatory. I mean, to deliver psychedelics to patients legally at an academic institution, there are a ton of regulatory hoops to jump through that require a lot of resources. So, we wouldn't have been able to do this study without funding from the Cohen Foundation. And I'm hoping that we're able to continue to, I'm hoping we're able to continue these type of studies, but I'm also hoping that, the regulatory bodies make this a little bit easier for the researchers to really answer the clinical questions that we need to have answered.
Thank you. Godspeed.
Thank you. Appreciate it.
Oh yeah, Tasha, go ahead. Sorry.
Perfect. Wasn't sure. Thank you for a great talk. I was wondering actually, where do you think microdosing fits into the kind of the landscape of psychedelic therapies for pain? Because there was this paper that came out, I think last year or the year before, where they administered microdoses to people in using experimental pain, and people reported greater pain relief from psychedelics versus a placebo.
Yeah, I forget, is that the LSD study where they basically tested pain perception?
Yeah. That's the one. I think there's
Mhm.
only one study that I
Yeah.
know of that does
Yeah.
that.
I mean, I think that I think it's also a complex question. There's a lot of facets to it. Acutely, I think it that study showed that it does improve pain or increase pain threshold.
Mhm.
But when patients are taking a microdose every day, I don't think it's really been elucidated what that does to the serotonin 2A receptors when you're taking an agonist every day. And
Mhm.
so in the patients oh, thanks, Court. Yeah.
Yeah.
In the in our little case series, the patients would take a sub kind of psychedelic dose, I think like once every month or once every 3 to 4 weeks. And
Mhm.
so they inferred benefit without needing to have that big, loss of ego or psychedelic experience. So
Mhm.
I think that there may be a use, and it'll depend on the specific patient, maybe how long they've been in chronic pain and how severe their pain and suffering is.
Mhm.
But I think it's, we talk about that all the time. Like what is kind of that threshold dose? Like, does someone need to really go through a full psychedelic experience, or is there something that's happening at the serotonin 2A receptor, as well as the downstream effects of that infer pain relief on its own?
Mm-hmm. And may I ask a follow-up question, relatively related? So I study placebo effects in pain, and so there's quite large placebo effects in pain. So
Mm-hmm.
how much of this improvement do you think that we see from psychedelics in pain is due to placebo? Because even things like lidocaine infusions or nerve blockers, even those are susceptible to some pretty substantial placebo effects. So how can we know whether psychedelics are better kind of pharmacologically or just through expectancy and such?
Yeah, I mean, that's why we chose phantom limb pain. That's one of the reasons why we chose phantom limb pain, because the majority of these patients have such severe and debilitating pain that hopefully that will kind of protect against that, at least partially protect against that placebo effect.
Mm-hmm.
But I think it's a really hard thing to it's hard. I think that especially with psychedelics, patients become unblinded very quickly
Yeah.
with with psychedelic doses. And so I don't know. Well, I guess we'll see.
Okay, good. Yeah, it's maybe to flip that, it's not necessarily a bad thing that there may be a placebo, but is there a way that maybe you could harness that? For example, providing a lower dose, but optimizing the setting or managing expectancy in a way where you wouldn't need them to do it as often or at as the same kind of dose, maybe even at a sub-perceptual dose.
Yeah. I mean, I think those are all kind of options. And I think that, I mean, as you can kind of tell right now, we have more questions than we have answered. I mean, this is one of the the first modern studies on the potential use of psychedelics for chronic pain. And when we kind of present the preliminary data, hopefully next year, I think that it's gonna, all of these questions are gonna come up, and it's gonna be really interesting to decide as a group where we go, like what question do we answer next.
Great, thank you.
You're welcome.
Thanks for your question. Kelly, go ahead.
Oh, looks like she's muted. Yeah,
hey, thank you so much for the presentation. I sent you a message earlier. I was like, oh, I read your paper with a great deal of interest. I used it, I referenced it. I committed it kind of to memory for a recent presentation that I did. And I think that there's been a lot of ideas that have come up, even just having a small group discussion like this about how we can kind of all collaborate and get some more research moving forward. The thing that I'm really intrigued by, so I've been practicing, I'm an anesthesiologist, so I don't like to put people to sleep just to give them pain relief, though, because it never seems to work, even if you give them tons and tons of ketamine. And I'm also a chronic pain doc. I've been working in the space for almost 15 years now. And the thing that I feel is maybe the most promising idea around psychedelics is really the ability to have people harness an alternate way of perceiving the mind-body connection. So patients that are really stuck, patients that refuse to accept that they have control over their pain. So I really like that you kind of discuss that idea of external locus of control versus internal locus of control. And one thing that I have been really mindful of is the type of patient that's really reluctant to accept things like psychotherapy. And I'm like, this might be our way in. Like, if we can say, what, this technique allows you to break down some of those mental barriers or some of those physical barriers that have been an impediment to improvement or even recovery. And I love that there is I know it's just like an N of one in a case study, but the idea that you can take somebody with phantom limb pain, which we know is incredibly difficult to treat and overwhelming, if that person can have complete resolution of pain, I think that that's something that we can easily present to patients that have really gotten stuck and mired down in this lack of ability to move forward. So I think that maybe what we really need to harness as practitioners is this a different element of this is just going to fit into the rest of your regime, but why not try it? So yeah. I'm looking forward to seeing what your group puts out and what all of the new information is coming. And I've been kind of touching base with people. If anybody wants to collaborate, I'm here and I'm in Calgary, so it's really cold. I have lots of time on my hand the next little while. So yeah, but thank you so much.
That's been one of the most refreshing things about kind of being involved in this space a little bit is it's so collaborative. I think that especially, the clinicians and researchers alike see these patients struggling, and that there's something that can potentially open kind of the door for them to improve in a different way. I think it's really exciting. And I think that a lot of people feel that way about psychedelics with whatever field they're in, whether it's business, whether it's, corporate finance. It's like, the psychedelics might be able to change the whole world here for the better. And I hope it's true, but I feel like my job as, a pain clinician and a pain researcher is to do the work and to make sure that there is a signal. I'm super passionate about it, but I want, regardless of whether it's psychedelics or something else, I want to be able to give patients as many opportunities as they can to improve their situation.
Right, thank you. And I just looking at the time here, maybe we'll just take up 3 more questions here. So Burton asks, is there a propensity for psychedelics to have more efficacy with psychologically related and functional etiologies of pain? So for example, fibromyalgia, complex regional pain syndrome, and somatoform disorders.
I think that fibromyalgia, somatoform disorders, and what was the third one?
Somatoform disorders.
Oh, see, yeah, complex regional pain. So, okay, yeah. I mean, I think that there is an opportunity that those type of like neuropathic kind of pathologic neural firing syndromes may be more beneficial. It may be more efficacious in those symptoms. And if so, that would be great, because those syndromes are really difficult to treat. There's work looking at the potential use of psychedelics for different eating disorders, whether it's binge eating disorders or anorexia nervosa, and then OCD. Obviously, anxiety and depression get the most pub. But I think to be determined. But I'm really hopeful.
Cool, thank you. Samantha here is asking, in your presentation, you mentioned 5-HT receptor agonists reset pathological neuroconnectivity to more efficient default mode networks. Could you clarify what this means and the connection to pain?
Yeah, so in functional imaging studies, specifically in patients with chronic pain, they are able to kind of identify different functional connectivity that is inefficient and pathologic. And the diagram that looked at both, but the theory is that with psychedelics, when you give someone, if you put someone through a fMRI scanner and you look at their functional connectivity, it shows that some areas of the brain are connected with other areas that are far away from it. And then when you give someone a psychedelic and you put them in an fMRI scanner, it seemingly all of the areas of the brain kind of talk with everywhere else. And then after that session is done, it resets the brain to a more efficient, more healthy default mode network, and kind of resets the brain from that neuropathologic connectivity pattern. I don't know if that answers the question, but
I think it does. Well, I think that's all the time we have today for questions. Dr. Castellanos, thank you once again for all the time and work that you put into this presentation. Just a quick some quick housekeeping before we leave for today. So quick announcement, we're not going to have a journal club in December because it's holiday times and I'm sure everyone is wrapping up the end of the year, but we're going to have our first journal club of 2023 on January the 10th. And our next speaker, I guess I could leak this now, but we're trying to have MindBed come in to kind of kick off the year really strong with a cool industrial talk. And so they'll come in and talk a little bit about their portfolio and what they're doing on both the clinical testing side and their digital medicine side. So a really interesting talk that we're preparing for everyone here. So we would love to see you all in 2023. And also, I just dropped into the chat all of our different contact information. So if you ever want to get in touch or share this journal club with other people in your network, please feel free to do so. We'd love to see more people here in 2023 as well. And so with that, thank you all so much for coming and hope you have a great rest of the year. Take care, everyone.